Good morning, guys. Today we will talk about the big topic. I need to tell you that topic you will discuss in the next year on the faculty of surgery. All your year will be acute abdomen, and you will discuss every disease what can lead to acute abdomen. Today, I just want to tell you what is the acute abdomen. Of course, the disclaimer. The lecture was created for scientific and educational purposes. It contains pictures and body knowledge of hearts and internal organs. The term acute abdomen should be confined to those patients with both acute abdominal pain and examination findings consistent with peritonitis. These findings often constitute a surgical emergency and should be managed as such. The term is not interchangeable with acute abdominal pain, and it specifically implies the highest level of abdominal surgical emergency. The management of patients with an acute abdomen comprises three concurrent processes: differential diagnosis, resuscitation, and definitive therapy, culmination in the decision to operate or to observe. Management of the acute abdomen you can see on the box number 68. Diagnostic, therapeutic, and operate or observe. Diagnostic include history and examination, assess severity, establish a differential diagnosis, seek information from multiple sources, investigations, explore specific diagnosis with directed investigations, preoperative investigations, general investigations. And therapeutic: resuscitation, airway and breathing control, establish early intravenous access, symptom control, analgesia, antiemesis, nasogastric tube if indicated, monitoring the patient, urinary catheter, oxygen saturation, invasive and non-invasive monitoring, non-surgical treatment, blood transfusion, intravenous fluids, intravenous antibiotics. If you want 3 on the exam, this box will enough for you. This process often complete with each other in a severely ill patient. Regardless of the severity of the presenting illness, management of patients with acute abdominal pain depends heavily on early and accurate establishment of the clinical diagnosis, or at least a workable differential diagnosis. These clinical diagnoses require accurate history taken, often from a number of sources, and careful examination. This is an important discipline to develop, and label acute abdomen should be regarded as a flag for urgent management and not simply for review at a later time. History and examination. Establishing a differential diagnosis or a definitive diagnosis of the acute abdomen by history and examination is achieved by two processes. The first is pattern recognition, redrawn from clinical experience, and the second is probability, based on the theoretical knowledge of what is most likely to be the cause given the circumstances. There you see regions of the abdomen and the reason, the causes, what can happen, what disease can happen with patient, and why he will have the pain in this region. I will ask this picture for everybody. The pattern of the pain is a very important factor to explore in the history. Two acutance of onset periodically, side radiation, and aggravation factors are features that give hints as to cause. These need to be explored in detail. Information with regard to this may need to be sought from multiple sources in the cases of a severely ill patient. The accurate history taken also often brings to light precipitation factors that give clues to the likely cause. The age, sex, and past medical history of the patient give helpful indication as to the likely cause when establishing a differential diagnosis. Specific examples of clinical patterns in patients with acute abdominal pain include the following. First, sudden onset of pain may indicate perforation of the gut, perforated ulcer, perforated diverticulum, foreign body perforation, or a vascular event, rupture, aneurysma, vascular occlusion. The sudden change in nature of the pain, cramping, to the sudden palpitation may indicate a perforation secondary to an obstruction. In the case of right iliac fossa pain in a female, the sudden onset of pain might be more likely to indicate ovarian pathology, cyst rupture or bleed, than appendicitis. Second one, syncope or collapse associated with abdominal pain suggests acute blood loss until proven otherwise. For example, a ruptured aneurysm or rupture ectopic pregnancy. Third one, combination of nausea and vomiting with abdominal pain is more suggestive for gastroenteritis. Vomiting and distension with abdominal pain is more suggestive of obstruction. And what you need to remember, and if we talk about the nausea and vomiting, more often people will come to you before they will have, for example, an vomiting. Yeah, they come with nausea, and it's very important to ask them when it come. Yeah, when it happened. For a colicky nature to the abdominal pain is suggestive of obstruction, and examination usually finds a relatively non-tender abdominal. Until a perforation or gut ischemia intervene to give peritonitis or an acute abdomen. Patients with renal colic are usually non-tender on examination, but have severe loin to groin pain. 5. A patient lying rigid in bed, whereby the pain is exacerbated by movement and with associated tachycardia and often hypotension, is indicative of peritonitis. Pain exacerbated by movement suggests peritoneal irritation, appendices, or musculoskeletal causes. Specific examples of the application of probability in the clinical setting include the following. First one, recent onset of abdominal pain in the right side of the abdomen and anorexia in a previously well young man, acute appendicitis. Second one, left iliac fossa pain and tenderness in a 60-year-old, sigmoid diverticulitis. Upper abdominal pain, back pain, and vomiting in a non-alcoholic, acute pancreatitis. Right upper quadrant pain and tenderness in a 30-year-old female, acute cholecystitis. And more often, these women have the 1 or 2 pregnancies before. It is beyond the scope of the chapter to cover all the possible clinical scenarios that account for patients who present with acute abdominal pain. At the heart of their management, however, is a determination on the part of the clinician to establish an accurate clinical differential diagnosis on the basis of history and examination and to direct further investigation and/or management. Indeed, an accurate history and examination may occasionally lead to immediate surgery. It is not possible at the outset to anticipate all the investigations that might ultimately prove helpful in patient diagnosis and management. Emergency surgical management should never be delayed by investigations that may not add to the information gathered from history and examination. In the event of a confident clinical diagnosis, acute appendicitis for example, in a fit individual, no confirmatory or diagnostic investigations may be deemed necessary. Numerous clinical factors affect the choice of initial diagnostic investigations, and some examples follow. First one, the severity of the presenting illness. Fast, focused assessment using sonography for trauma. It is a very important term, you need to remember this one. In the emergency department, if an intra-abdominal catastrophe is suspected, this is an ultrasound. Yeah, the sonography would give us really fast understanding of the situation in the patient. Full blood count and cross match if hemorrhage is suspected. Specific diagnostic possibilities. Serum beta human chorionic gonadotropin is in suspected ruptured ectopic pregnancy. Serum amylase or lipase in suspected acute pancreatitis, abdominal ultrasound in cases of suspected biliary disease, obstructive uropathy, ruptured abdominal aortic aneurysm. 12-lead ECG in suspected acute myocardial infarction. Yeah, please remembering that sometimes acute abdomen it is the symptom of myocardial infarction. Urine dipstick and midstream urine catheter specimen of urine should be performed as urinary tract infections often mimic many other abdominal conditions. Third one, if surgery is anticipated prior to undergoing a general anesthetic, certain investigations may be obtained, particularly in older patients, as a routine. This will vary from center to center, but such tests include urea and electrolytes, full blood count, ECG, chest X-ray, as well as cross-match in appropriate cases. General investigations in patients with acute abdominal pain of uncertain origin. These investigations may direct further intervention or flag a previously unrecognized degree of severity. Even before a clinical diagnosis is formulated, certain diagnostic investigations may have been investigated in anticipation of subsequent need. Many centers have routine investigations set performed on presentation of the patient to aid efficiency. Amongst these, those most frequently of value are as follows. Full blood count. Elevation of the white cell count is a cardinal sign of sepsis, but it may also be raised by the stress of pain alone. It is also mildly elevated during normal pregnancy. In general, an elevation of white cell count should never be dismissed, and a very high white cell count in the context of a patient with acute abdominal pain raises the possibility of intestinal perforation, peritonitis, or ischemia. Hollow viscous perforation, mesenteric infection, closed loop, small bowel obstruction. A supine abdominal X-ray reveals a distinction of intra-abdominal gas, intestinal obstruction, thickness of intestinal wall, mesenteric ischemia, abnormal calcification, ureteric colic, chronic pancreatitis, and outlines the psoas shadows, possibly obscured in ruptured abdominal aortic aneurysm. The erect abdominal chest X-ray reveals fluid levels of free gas under the diaphragm. I need to tell you guys that more often it don't really help us in every disease. We use X-ray of abdomen when we need found the gas in the abdominal cavity, free gas in the abdominal cavity, and when we need found intestinal obstruction. These two situations where X-ray really will help us to find this disease. Ultrasound. Inexperienced hands may reveal free fluid suggestive of hemorrhage or perforation. There you see the pancreas. It is a yellow line. Deeper or under confluence splenic vein. Superficial mesenteric artery. Left renal vein. Aorta, inferior vena cava, and vertebra. Of course, when you take it first time the ultrasound, it's too hard to understand what you see. And this is a practice, this is a training, and no more else. CT may reveal or confirm the diagnosis and is not readily available. A CT scan should not be performed in an unstable patient. Not be used to replace accurate and rigorous clinical history and examination. Therapeutic. At the same time as these diagnostic steps are being taken, concurrent therapeutic management should be undertaken. This includes the following broad groups. Resuscitation. Unwell patients may require preliminary resuscitation before any practical diagnostic steps can be taken. Tachycardia, hypotension, pallor, sweating, and cool extremities all suggest a more severe clinical presentation, and the possibility of sepsis or hypovolemia. Immediate intravenous access should be established and fluid replacement appropriate to the clinical setting commented. Oxygen should be administered to maximize vital organ oxygenation. If conscious state is compromised, early airway management should be undertaken. In case of hemorrhagic shock, a blood transfusion should commence as soon as practicable. But you need to remember the indication for the blood transfusion, and indication is the less of level of hemoglobin less than 80 and degree of hematocrit less than 25. However, transfusion should not be low to delay the commencement of urgently needed surgery, where the need to control the bleeding point outweighs the desire to restore intravascular volume by transfusion. In the acute setting, it is easy to overlook the need to provide basic symptom control. Analgesia should not be withheld pending surgical review. Analgesia requirements are usually an excellent indicator of the degree of pain being suffered by the patient. Antiemetic therapy usually accompanies opiate analgesics. For repeated vomiting, another gastric tube should be paced. This will relieve the symptoms, permit more accurate measurement of fluid loss, and protect the patient from the risk of aspiration of gastric contents. Urinary retention often accompanies the acute abdomen, and the urinary catheter should be inserted to also aid fluid balance monitoring. Monitoring the patient. In the severely unwell patient, it is important to monitor the outcome of resuscitation and fluid replacement. Apart from the standard vital signs, pulse rate, blood pressure, temperature, additional information can be obtained by measuring urine output. Indwelling urinary catheter and invasive arterial line or central venous line, or non-invasive cardiovascular monitoring. These measures are more sensitive to changes in intravascular fluid status than are the pulse rate and blood pressure. Non-surgical therapy. Broad-spectrum antibiotics should be administered according to the likely clinical diagnosis. This may precede the formulation of an accurate clinical diagnosis, especially in unwell patients. Agents active against gram-negative bacilli and anaerobic organisms are generally preferred in patients presenting with acute abdominal pain. In cases of suspected peptic ulcer complications, intravenous proton pump inhibitors should be administered. In the anticoagulated patient, reversal of anticoagulation may need to be considered if possible when bleeding is suspected or surgery is planned. Surgery versus observation. Ultimately, an assessment needs to be made about the need for surgery. This may be clear-cut where a confident clinical diagnosis has been made. I need to tell you that now more often we use the laparoscopic diagnostic, and it helps us to understand it is important to do any operation for this patient. But what you need to understand that laparoscopic diagnostic, it is a operation, it is a surgery, and it is invasive manipulation, and I think that it is the surgery. And when we look to the abdomen, we see the cause, the reason of the pain, and we start to do any surgery maneuvers. In some cases, advanced age or infirmity might caution against surgery, even where a confident diagnosis points to a surgical remedy. Rupture abdominal aneurysm in a frail 90-year-old. Significant concerns in this situation about goals of care, imitations of care, and end-of-life care need to be incorporated into the clinical discussion. No, this is a very hard question. Often, however, the precise diagnosis is uncertain and the need for urgent surgery is made obvious by virtue of either the clinical features of generalized peritonitis or the severity of the presenting illness. In this situation, clinical experience enables early identification of the need for prompt surgical intervention, often without further investigations. Where the need for surgery is unclear, observation, resuscitation, and non-surgical treatment of the likely diagnosis rather than exploratory surgery is appropriate. This involves regular clinical review conducted at a frequency appropriate to the severity of the illness. For example, review in 12 hours for a 20-year-old woman with mild right iliac fossa pain and tenderness, or in 1-2 hours for a 75-year-old man with small bowel obstruction and associated abdominal tenderness. At times, such review may be augmented by further laboratory or radiological investigations. Of these, the white cell count and C-reactive protein are most often of practical value. A rising white cell count, or CRP, generally indicates progression of the underlying pathological process. The clinical scenario described in box serves as a demonstration of the dual process, diagnostic and therapeutic, in the management of a patient with acute abdominal pain. Note especially the rapid construction of a workable differential diagnosis to permit subsequent history and examination to focus on identifying the most likely diagnosis. Yeah, there you see the 65-year-old man presents with the sudden onset of generalized abdominal pain and collapse. On examination, he is pale, sweaty, and distressed, with pulse rate of 110 beats, blood pressure 90/50, and temperature 36. Diagnostic history and examination establish and explore the likely differential diagnosis: rupture abdominal aortic aneurysm, mesenteric infarction, perforated peptic ulcer, acute pancreatitis, acute myocardial infection. Resuscitation: adequate intravenous access, oxygen mask, transfuse if hemoglobin less than 8. Before the normal hemoglobin in patients with acute hemorrhage, normal value does not rule out acute bleeding. Consider transfusion if hemoglobin less than 10. Symptom control, monitoring the patient, non-surgical treatment. And investigation: full blood count, urea and electrolytes to get resuscitation. And other investigations: serum, lactate and blood gases, ECG, abdominal X-ray. There we want to find free intraperitoneal gas, loss of psoas shadow, never see it. Classification of the abdominal aortic aneurysm, never see it in the X-ray. Classification: dilated loops of small intestine, never see the loops, always see the symptom of Kloiber's cups. Serum, amylase, lipase, diagnostic for acute pancreatitis. Cross-match if hemorrhage is suspected and or Mayer surgery anticipated. Fast scan to confirm rupture abdominal aortic aneurysm, for example, or bleeding inside the abdomen. Investigation should not delay surgical management in order to ruin patient or a patient not responding to resuscitation. And there you see the non-surgical treatment and intravenous antibiotics, high-dose PPIs. Operate to observe: rupture abdominal aortic aneurysm, immediate laparotomy or angiographic stenting depending on facility. Perforated peptic ulcer, immediate operation, occasionally may be treated by antibiotics, PPIs, and observation if abdominal signs are localized. Mesenteric infection, immediate operation to exclude closed loop small bone obstruction. Acute pancreatitis, intravenous fluid replacement, analgesia, oxygen administration, nasogastric tube if vomiting, urinary catheter for fluid balance monitoring. Observe for progressive abdominal signs, features of intra-abdominal sepsis. Monitor full blood count, liver function test, serum, calcium, blood glucose level, arterial blood gases, and CRP. Yes, see that there we don't do the operate. Acute myocardial infarction, monitor patient in critical care facility, specific therapy according to local protocols. Yes, abdominal topic of acute abdomen we finished. Now we need to talk about peritonitis. It is not much words, but it's very important. First of all, I want from you to look what is the peritoneum. Peritonitis is defined as an inflammation of the peritoneum of whatever underlying cause. As previously discussed in the section on acute abdomen, peritonitis is an essential feature of the clinical syndrome, but is also a feature of other more localized disease of the peritoneal cavity causing acute abdominal pain. Often the peritonitis is localized to a particular area of the abdomen, and this occurs due to the body's ability to contain the inflammatory process by wrapping of the omentum. This containment may eventually lead to a localized abscess or progress to generalized peritonitis and an acute abdomen. This progression may be accompanied by marked ileus, hypovolemia, toxemia, or even septicemia. Cardinal signs of peritonitis are tenderness, gorging, and rebound over the specific area of the whole abdomen, in this case of diffuse peritonitis. Fever, tachycardia, and dehydration are common features, and movement generally exacerbates the pain. Causes of peritonitis, acute and secondary. Look, we have this tertiary peritonitis, but in this year we will discuss about tertiary peritonitis. Acute peritonitis, we had primary, spontaneous, secondary, acute purpurative, chemical-induced. Chronic peritonitis, infectious, chemical-induced, and carcinomatosis. Acute primary peritonitis is rare and usually occurs in association with immunosuppression, such as post-splenectomy, renal disease, or in cirrhosis, where the proteinaceous acidic fluid provides a good culture medium for bacteria. Sometimes it affects young girls following pelvic inflammatory disease. Commonly involved organisms include hemolytic Streptococcus, Escherichia coli, and Klebsiella species. Acute primary peritonitis is often a diagnosis of exclusion and requires aggression antibiotic therapy. Secondary peritonitis may be suppurative, chemical, or chronic sclerosing. I need to tell you that this information is English information from American book. In Russia we have another classification, and we will talk about this one in ending of our lecture. Acute suppurative peritonitis may occur secondary to a disease process of an intra-abdominal organ. Perforation, for example, of the gut. Yeah, you see the gas on the X-ray. It is there. There is the diaphragm, white line. There is the lung, black, and there is the gas under the diaphragm. Infection or ischemia. Most of these cases will require urgent surgical intervention. Erect chest X-ray may show free gas beneath the diaphragm, indication a perforated viscus, and clinical findings may suggest an acute abdomen. By the nature of the effusion, we have 6 types of the peritonitis: serous, fibrinous, fibrinous purulent, purulent, hemorrhagic, and putrefactive peritonitis. According to the prevalence of the pathological process in the abdominal cavity, we have local and diffuse peritonitis. But look, diffuse is not right term for this one. I think the better is extended or widespread. We will call it widespread or extended because this type of peritonitis will delay it for diffuse and some more. Local peritonitis is divided into limited, abscess, inflammatory infiltrate, and unlimited. There are no joints limiting the pathological process. It is localized in one of the region of the peritoneum. Extended peritonitis, or widespread. There we have diffuse. The inflammatory process engulfs the peritoneum for considerable length, at least 2 floors of the abdominal cavity. And spiraled or poured. The inflammatory process spreads to the peritoneum of the entire abdominal cavity. In the pathogenesis of widespread or extended peritonitis, depending on the time that has elapsed since the onset of the disease, there are 3 stages, each of which has its own clinical picture. The 3 stages I don't found in the English literature, just in Russian literature, and it is really important to you to remember in this one because it will help you to save your patients. Stage 1 is reactive. It is the first 24 hours, which is the body's reaction to infection of the abdominal cavity, characterized by a sharp pain symptom, pronounced tension of the muscle of the anterior abdominal wall, nausea, vomiting, restless behavior of the patient. Second one, pain of an intense and permanent nature is localized in the zone of development of the pathological process. It increases with a change in the position of the patient's body. or you can please him to coughing and the pain will increase. To reduce the intensity of pain, the patient tries to lie on his back or on his side with his legs brought to his stomach and avoid unnecessary movements. The tension of the muscles of the anterior abdominal wall is detected by surface palpation of the abdomen. It is more pronounced in the area of locality of changes in the parietal peritoneum. Muscle protection is especially pronounced in peritonitis, which occurs during perforation of the hollow organs of the abdominal cavity. Plank-shaped abdomen. Common symptoms at this stage are manifested by an increased pulse rate up to 120 beats per minute, increased blood pressure, increased breathing, increased temperature, and a moderate pronounced toxic shift in the blood formula. Stage 2. Toxic. (24-72 hours). The stage of subsiding of local symptoms and a more pronounced general reaction of the body, which is a response to the entry into the bloodstream of exo-endotoxins and enzymes produced by bacteria, as well as toxic substances accumulation in tissues as a result of disruption of normal metabolic process. In its clinical manifestations, this stage is similar to the clinical pictures of endotoxic shock. At this stage, the intensity of pain decreases somewhat, regurgitation and vomiting of brown liquid appear, there is a delay in stool and gas discharge. Frequency, the pulse rate increases more than 120 beats, blood pressure decreases, body temperature remains high, more than 38, shortness of breath appears, facial features sharpen, tongue is dry, like a brush. The abdomen increases in size due to intestinal paralysis, the symptoms of muscle protection weakness somewhat. There is a decrease in the volume of circulation blood, the amount of protein in the blood decreases, in the acid-base state is disturbed. The third one is the terminal stage, more than 72 hours, the stage of pronounced intoxication on the verge of reversibility, when local and general mechanisms of protection of the body from infectious aggression lose their activity. At this stage of peritonitis, symptoms of damage to the central nervous system develop adenomia, confusion, and delirium. In some cases, patients experience euphoria with psychomotor agitations. In this stage, the skin becomes sharply pale, acrocyanosis appears, facial features sharpen, eyeballs sink. We call it facies hypocratica. There are pronounced respiratory and cardiovascular disorders. Breathing becomes very frequent, shallow pulse is frequent, blood pressure decreases. This stage is characterized by impaired motility of the gastrointestinal tract. Vomiting is observed with a large amount of gastric and intestinal contents with a fecal odor. The abdomen increases in size. Intestinal noises are not heard. The people will die in this stage. Thank you very much for your attention. I repeat you that we just start talking about peritonitis, and in the next year we will talk about it one more. Bye bye, have a nice day.